start in order to get some time for final discussion to make the session more enjoyable and more producing in learning points. If you agree, everybody agrees, we should start. Okay. Well, from the organizers, do we know if we are online already?
It seems that they are all online, as I can see here. Yes.
Okay, then.
It's only Takanori who is missing.
Yeah, I know. That's why I'm asking, should we wait more or should we start?
We should start. We don't know when he will be successful to join, right?
Okay. Okay, then, dear colleagues, it's my pleasure to moderate this session that it's dedicated to challenging ECG tracings. I'm moderating this session together with Dr. Takanori Ikeda from Japan, and we will have as panelists in the last part of this session Yigang Li from China, Thomas Klingenheben from Deutschland, Leandro Tomas from Argentina. So, in the interest of time, I will invite first our young colleagues, Cosmin Cojocaru from Romania, to present emergency department challenges. Cosmin?
Greetings, just 1 second. Okay, I hope you see my screen.
Yes.
Perfect. Okay, thank you very much for the invitation. My name is Cosmin Cojocaru. I'm part of the faculty in Bucharest, and I work in the emergency clinical hospital of Bucharest. Thank you so much for the invitation today. I'm going to start my my presentation with one of the Monday on-call cases, in which a 30-year-old male presented to the emergency room with palpitations and presyncope, and this ECG tracing was obtained, in which we can observe a white QRS tachycardia, in which we don't really see the atrial activity, but we see an RBB morphology with an unusual wide QRS complex. And what did we use in our analysis? Firstly, we saw that it's easy to see that the patient is developing an RBBB wide QRS tachycardia with a very wide QRS. And based on the criteria, based on the AVR lead, we can see there is quite a large Q wave in the initial Q wave in AVR, and the patient's symptoms developed after cycling after effort. We decided to perform cardioversion in the emergency department, and this ECG tracing on right is the tracing that was obtained after conversion, in which we can see a sinus tachycardia with quite a narrow QRS and no really obvious structural pathological changes in the QRS. However, if we look closely in lead V3, we can see somewhat of fragmentation of the QRS and a discrete widening of the QRS. On top of that, the patient's bedside echography was absolutely normal. So we have all these criteria that incline the favor of tachycardia being a ventricular tachycardia. So in our opinion, considering the patient's absence of structural heart disease and the patient's age, we wanted to make a differential diagnosis between a ventricular tachycardia and an antidromic AVRT. Ultimately, we performed an electrophysiological study which objectified the left accessory pathway. What message we want to send by this case is that in wide complex tachycardias, with no visible atrial activity, we obviously use the rule of thumb. We always think of VT, but it's highly important that we always integrate all the patient's history details, echography details, and baseline ECG. Even if the patient develops, so to say, benign arrhythmias, not this being the case, obviously, but we always have to weigh in structural heart disease, even in the presence of more benign arrhythmias. The second case is one of what is quite a direct case of a 70-year-old in the emergency department that was brought after developing cardiac arrest after shopping with his wife, in which we can see rhythm, which is not preceded by P wave before the QRS, and we see a somewhat strange morphology of the QRS. And if we look in the inferior leads, we can see that it's a typical aspect of ST elevation myocardial infarction, but in a very specific morphology called the shark fin phenomenon. Initially, this patient was brought to the emergency department after having developed ventricular fibrillation and was promptly resuscitated. But the ambulance observations, the ambulance doctors thought of this ECG tracing initially being an ECG caused by hyperkalemia, and this delayed the patient's transportation to the hospital. If we look closely in the lateral leads, it's a lot easier to observe the J point. And moreover, we can, if we look closely in lead D2, we can see that there's actually a junctional rhythm with the retrograde B wave, and with the right bundled branch morphology and left posterior hemiblock. So, in conclusion, this was a typical ECG of ST elevation inferior posterior myocardial infarction, but with a shark fin phenomenon, and this led to the activation of Cath Lab and showed the RCA osteal occlusion. In conclusion, be mindful that this phenomena can lead to confusion with wide QRSs, and it's of critical importance that we have to observe it, and we have to notice that, and we have to know that this ECG morphology is associated with occlusions of most frequently appears in LAD and left main occlusions with no collaterals. This being another typical example of an LAD occlusion with no collateralization. In the interest of time, this next one is my last presented case, and it's about an 82-year-old male which presented to the emergency room with new onset chest pain, and by having a history of single chamber ventricular pacemaker being implanted. And what we can see is difficult to observe atrial activities, most probably atrial fibrillation with complete AV block and ventricular pacing with an apical right ventricular lead, in which for which the patient was brought to the emergency department because the emergency doctors remarked that there are certain pathological signs concerning the repolarization in this particular tracing. So what we saw is that there is concordant ST elevation in AVR, which is highly pathological, and concordant ST changes in D2, D3, AVF, V5, and V6. So based on Scarbosa criteria for paced rhythms, we could say that this patient would have a 5-point score based on the concordant ST elevation in AVR. So this patient would be sent for Cath Lab. Moving on, during the patient's transition to the hospital, obvious ST elevation developed in the precordial leads, and this made the diagnosis a lot more easier. So the patient was loaded with antiplatelets and heparin, and Cath Lab was activated. Prior to angiography, we saw dynamic changes in the patient's ECG as the ST elevation on the precordial leads started to improve, which might have meant spontaneous reperfusion. Although we see that there is progressive necrosis in the precordial leads with the QRS widening and the deep Q development. What I wanted to underline is that starting from the initial criteria of Scarbosa in 1996, these criteria gained sensitivity in 2012 when Smith launched a new modified Scarbosa criteria, which raised sensitivity and gave us the benefit of identifying more cases of acute vascular occlusion in LBBB or LBB-like paced rhythms. However, I want to underline the new algorithm that that should be used, which is, so to say, the new kid on the left bundle branch block by the Barcelona algorithm, which provided a bit more changes than the previous two, by including firstly the possibility of taking relevance of ST depressions in any ECG leads rather than V1, V2, and V3 in the original ones, and V1, V6 in the modified, and the fact that you can expect to have discordant ST deviations in comparison to QRS polarity, but not of 5 millimeters that used to be in the original Scarbosa criteria. And these subset of criteria that were added to the Barcelona algorithm raised a lot the sensitivity of this diagnostic algorithm. And they say that there is similar diagnostic accuracy when you apply the Barcelona algorithm to patients without LBBB. So the take-home message from this case is be mindful of these patients which are previously implanted with pacemakers, because they are also at high risk for coronary artery disease, and always be mindful of overlapped changes. Thank you.
Thank you, Cosmin. It was a very nice presentation. We will discuss at the end, as this session is structured in such a way. So I will invite Dr. Ikeda Takanori is with us. Maybe he would like to introduce the next speaker. I think you should open your microphone. We cannot hear you. No, your mic.
Yes. Very sorry, I'm delayed to attend this meeting. So I think a very nice presentations. We learned a lot of things, emergency department challenges. Actually, I have no questions. Thomas, do you have questions? Please release mute. Yes.
We should. Do you think that we should address questions now or at the end when it's a discussion with the panelists?
Okay. Yeah. Please move on.
Yeah, maybe we'll give more time to the audience to raise questions. Okay. Would you like to introduce the next speaker, or?
Yes, please introduce the next speaker.
The next speaker is Dr. Ahmet Çağdaş Yumurtaş from Turkey, showing us ECG with lessons from the Cath Lab. So maybe it's a nice connection with the previous presentation.
Yes, thank you. Yes, you can see my screen, right?
Yeah.
Yes, we can see. Yeah. Please go ahead.
Dear moderators and dear colleagues, I hope you are having an enjoyable Congress. First of all, I would like to thank ISE committee for giving such an opportunity to speak. In this presentation, I will talk about difficult cardiac rhythms that we may encounter during the procedure in Cath Lab, and Cath Labs, which are, so to speak, the habitat of interventional cardiologists, are also one of the places where nightmare scenarios can happen. Of course, we all want to see such a normal sinus rhythm during this procedure. And during the procedure, we must keep one eye on the monitor and act calmly and quickly in case of a possible arrhythmia. So what can we face? Perhaps one of the most common conditions we encounter is bradycardia due to increased vagal tone. Especially during the puncture, patient may experience worsening and decrease in blood pressure accompanied by bradycardia. Such situations are usually seen in female patients. In addition, bradycardia may develop following revascularizations, especially in inferior myocardial infarctions. In the meantime, we must be careful and we can give patient command to cough. If we are unsuccessful, we can use atropine also. Another common rhythm is idioventricular rhythms. Accepted mechanism is increased ventricular automaticity and is also associated with increased vagal tone. And these rhythms can develop following revascularization in acute ST elevated MI patients. It is a benign rhythm and it is usually self-limiting and spontaneously transforms into normal sinus rhythm. And the AV blocks consist of 3 degrees. While it can be seen at the beginning of the procedure in some inferior MI patients, or it may be due to hyperacute stent thrombosis during the procedure in some patients. We should be careful against a possible AV block, especially when attempting to procedure in the right coronary artery. We are usually not immediately alert when we see ST segment depressions. This change, which can develop in many scenarios, may result in a decrease or increase in the patient's coronary blood flow. It can be seen in conditions such as vasospasm or during intracoronary nitrate administration. If this situation lasts longer than a few minutes, we should be alert slowly. And the ST segment elevation is among the rhythms that the operator doesn't want to see during the procedure. It can often be seen as expected during balloon or stent implantation in the coronary artery. In addition, reocclusion of the vessel predilated by the balloon. It can also be seen during no reflow or stent thrombosis. If we encounter such a situation, we need to act quickly. And if we don't, malin arrhythmias can develop. Here you are seeing such some ventricular tachycardias type. It can be seen as monomorphic, polymorphic, or non-sustained. This situation is more common in patients who are already at very high risk during the processing. And if we see this scenario, we must start CPR and defibrillate quickly without wasting time. It mostly occurs in delayed MI patients or as a result of complications such as, again, no reflow during the procedure. Perhaps this is one of the rhythms where we get most nervous when we see it in Cath Lab, and where we often call a support people to Cath Lab. Patient may be talking to you normally in 2 or 3 seconds of ventricular fibrillation. We must manage the chaos that develops with the sudden onset of contractions. We must start the intervention quickly with CPR first, and we must use defibrillator. We should pay attention also ventricular extrasystole, which are the starters of this situation. As you can see in the right picture, RONT following ventricular extrasystole and transforms to VF. As asystole is one of the horrible rhythms, of course, in which the blood pressure of operator decreases, including patient. It is observed during the procedures of delayed MI patient as a result of myocardial depressions due to complications developing during the procedure. In such situation, all we have to do is do CPR and keep the motivation high until we get a BP response. And of course, we shouldn't shock every arrhythmia we see on the monitor here. The patient's current rhythm imitates VF depending on the movements of patients. We shouldn't forget about artifacts either. Otherwise, we may cook the patient. Thank you for your patience.
Thank you, Dr. Yumurtaş, for your interesting presentation. Dr. Ikeda, do you think?
Yes, yeah, very nice presentation. I have one question. When you saw a ventricular fibrillation in Cath Lab, immediately you will do a direct current shock. After that, what kind of medicine are you using in your country? That's my questions.
Yeah. If we face when in Cath Lab, actually we shock the patient and we are continuing processing the intervention, and it would incessant VF or VT. First we use amiodarone.
Amiodarone, intravenous amiodarone. You will okay. You put and okay. So in your country, never use a lidocaine. Is that correct? After direct current shock.
Yeah, lidocaine is a short half time, and amiodarone is maybe the good choice, better than lidocaine.
I completely agree with you. Other question or comment?
Sorry, I have one question for Dr. Cojocaru, the first presentation. Doctor, excellent presentation. In the first case, in the accessorial pathway, would you have used adenosine?
Yes.
Thank you for your question. Well, considering the patient's clinical context, so young age, no formerly known structural heart disease, if the patient is hemodynamically stable upon presentation, which the patient was, we could have used adenosine by thinking if it was an AVRT, antidromic AVRT, would have converted the patient. If it were a VT, it would have no effect. But in this particular case, we went straight to electrical conversion. But in theory, if you have such a case with the condition the patient is hemodynamically stable and does not have a particular clinical context, such as triple bypass in the history or something like that, in which you can, in which negative effects can develop from adenosine. So in this particular patient, we could have used adenosine in the beginning if the patient was hemodynamically stable, in my opinion.
Thank you.
You can use also vagal maneuvers anytime.
Obviously, you start with vagal maneuvers. It's easier and simpler. Yeah. Thank you.
Dr. Ikeda, would you like to introduce the next speaker?
Yes, please. Yes. Okay. Next speaker is Dr. Ema Goanţă from Romania. She will present a lesson from the EP lab. Could you share your slide and please start your presentation?
Just a moment.
That's also
that'd be great. Yeah.
In the meantime, okay.
Okay, please start.
If it's
yes.
ready, okay.
Yeah, we see it. Now we can see it. Yeah.
So Ema
Yes,
will
we can
present
see
and
it.
Cosmin will
So
help.
thank you, Cosmin. Good afternoon to everyone, and thank you for the invitation. I will have only the text for today's lessons from the EP lab, and I have only one case presentation. Cosmin, please, the next slide. Next. Okay, so it is a woman, 60 years old woman with a history of repeated episode of SVT in the last 2 years. Stopped in the emergency department using vagal maneuvers and adenosine, and this is only EKG the patient has in tachycardia, and you can see it is a narrow QRS tachycardia with retrograde P waves after each QRS complex, and we have a PR RP interval, short RP interval, 70 milliseconds, which is compatible with AV and RT. Next, please. So she was brought to the AP lab for AP study and ablation. Her clinician didn't find any underlying disease and her echo was apparently normal prior to procedure. Her EP physician didn't examine the patient or the case before the procedure, but she saw only the EKG in tachycardia. Next, please. So we have here the AP study, and on the left side, we only use 2 catheters, and we have a decapolar diagnostic catheter in the CS, and also an ablation catheter used for mapping. And we see on the left side the ablation catheter on the his region, and we see normal AV and HV interval. And on the right side, we see the ablation catheter in the right ventricle, and we can see a programmed ventricular stimulation. And we have a retrograde atrial conduction through the AV node, concentric decremental. Please, next please. So during atrial incremental pacing, we have 1-to-1 AV conduction through the slow pathway, and we have the induction of the atrial of the tachycardia with a long AV interval and a short HV interval compatible with typical AV NRT. Next, please. That's why we proceeded to ablation of the slow pathway, and we see on the left side ablation of the slow pathway, an image on the left anterior oblique projection. This is not the typical side. We have a superior side superior to the CS ostium, but this was the only place where we could obtain stable, sustained junctional rhythm. Next, please. After atropine administration for retesting, she experienced multiple extra beats, PVCs, with left bundle branch morphology, inferior and superior axis. But when we took a look on her surface EKG, we could also see that she had some repolarization abnormality in the right precordial leads. Next, please. Same thing was also on her baseline EKG prior to ablation. She had a T wave, negative T waves from V1 to V4. She had multiple PVCs from with a morphology of left bundle branch block, negative inferior and superior axis, and also when after the procedure, when we changed the settings of the EKG, we saw also some epsilon waves in V1 and V2. Although the clinician told us she didn't have any underlying disease, the patient was referred for a coronary angiography 11 years prior to ablation due to her EKG, and she had also some positive history of sudden cardiac death. Her grandmother died suddenly when she was young. Next, please. So because the suspicion of arrhythmogenic cardiomyopathy, ACM, had been raised during the procedure and the patient was on the table, a ventricular induction study using 4 extra beats was performed, negative for ventricular arrhythmias. Next, please. After the procedure, we repeated the echo, and the image was very poor, but we can see on the right side that we have a normal left ejection fraction. But although the ventricle, the right ventricle has a normal diameter, we can see it has a diastolic dysfunction and also has a mild tricuspid regurgitation. Next, please. So in on the 4-chamber view, we can see the right ventricle has multiple trabeculations and also it is dyskinetic. Next, please. That's why we refer the patient for an MRI scan, and during the MRI scan, we see multiple areas of dyskinesia and the outflow tract and mid-apical level of the free all. And also we see the doctor told us, the imagist told us that the global dysfunction was, we had a global dysfunction moderate of the right ventricle of 36%. This fulfilling the Padua criteria for ACM. Next, please. After MRI scan with the patient, the testing was positive for pacofilin, which is the most frequent gene in ACM, and give us a phenotype, a classic phenotype of ACM, affecting predominant the right ventricle. Next, please. But what about supraventricular tachycardia in these patients? Mostly the most frequent atrial arrhythmias are atrial fibrillation and atrial flutter. And this is due to advanced age, heart failure, enlarged right and left atrium, and due to significant mitral tricuspid regurgitation. And very rare, we see a AV NRT case in this patient. Next, please. Next slide. So we have an ICM patient, and in which we perform SVT ablation. What should we do next? Should we implant an ICD in primary prevention or not? Next, please. So we use a Holter EKG to see the burden of the PVC, and actually using the risk calculator, the patient was old. She didn't experience any syncope and didn't have any VT tachycardia. That's why the risk of sustained ventricular arrhythmia was 4.8% in a year. That's why we talked to the patient and we decided to leave her on beta blocker treatment and to have a restrictive activity, physical activity. But unfortunately, next please. Next. After more than 6 months, now the previous one, please. Okay, thank you. After ablation, 8 months after ablation, she presented to the emergency department with syncope preceded by palpitation, and we decided to implant ICD. Next, please. So to conclude, the lesson from the AP lab: always see the patient before any AP procedure. EKG is a very powerful tool, and if you have T-wave inversion in V1, V3, and ectopic beats from different areas of the right ventricle, it is highly possible to have a ACM. SVT are common in ACM, and predominantly atrial fibrillation and atrial flutter, as this is due to progression of the underlying disease. And the AVNRT is very rare. Although we consider many arrhythmias benign, this case shows us this is not always true due to an intricate malignant substrate. Thank you.
Thank you very much.
Thank you.
Are there any questions or comments?
I might have some, because it's a, I mean, first the panelists, if some of the panelists wants to comment.
Mm-hmm.
If not, I would have a very, very fast, because I want, this is a session that should teach us things, especially for young. So yes, negative T waves in precordial is that it's extended to V3 or beyond V3. Should always raise attention to arrhythmogenic cardiomyopathy. However, I wouldn't consider that patient having an epsilon wave. When you do amplification with 20 millimeter per millivolt, I think it's questionable, especially when you do. I wouldn't consider that patient to the. And also, I think programmed ventricular stimulation in arrhythmogenic cardiomyopathy, it's not something that it's accepted as a reliable tool, except for the fact that in rare instances that we are able to induce monomorphic VTs. That's the only thing. And I think there are studies from the Bordeaux group showing that when you use Isuprel, it's actually it's a more reliable solution to unveil potential for malignant arrhythmias in these patients. And on top, what it's also important, it's very good that the patient get genetic testing, but we should move always forward. I mean, it's an autosomal dominant mutation. So automatically should be followed by the family screening. That's, I think, very important. And last but not least, in a patient with a previous supraventricular arrhythmias except AV-NRT, which is very rare in arrhythmogenic cardiomyopathy. It's not an association. It's not more than in general population, by contrast to Brugada syndrome. Atrial arrhythmias like atrial fibrillation, flutter in this patient are usually a marker of more extensive disease when you have atrial involvement. And it's not the case for that patient. And I say last but not least, in a patient that has a previous slow pathway ablation, and she's on a beta blocker and has a syncope, before deciding an ICD, this is the moment that I would probably repeat an EP study. Because sometimes there may be some conduction anomaly, there may be AV-NRT recurrence that sometimes is going with presyncope or syncope. So I don't think it was such a clear indication for an ICD, but it's also the patient preference that we should discuss always.
Okay. Okay, other comments or a question?
Yes, I also have a comment. First, I think it's a fantastic case. Thank you. I agree. I agree with Radu that it might be questionable to implant an ICD. According to syncope guidelines, one could also discuss to implant a loop recording system first and have a look to these patients. I think that would perhaps in that case be a better solution. But again, I agree it may be on patient preferences and the circumstances to decide for an ICD. I probably would have chosen a loop recorder first before deciding whether the patient would need an ICD or not. The other thing I would like to ask you is sometimes we see AV nodal reentrant tachycardia as a first manifestation in older people, and I think that we should, we know that many of these reentrant tachycardias are induced by ventricular extrasystole. So it would be interesting if there's a first manifestation in elderly people to, at least after an ablation procedure, to look further why these patients have extrasystoles and whether this may be cause for underlying disease. I remember a patient who finally was diagnosed with coronary artery disease following an ablation for simple AV-NRT. So I don't know what your experience is in these elderly patients who have a first manifestation of supraventricular reentrant, in which may be just according to the fact that they have more and more ventricular extrasystoles, which by themselves may be a sign for something, you know. Do you have an idea or just a comment to that?
Please release, mute. Yeah, release mute.
Microphone.
Yeah.
Can you hear me? So may I? It's a great case actually. Very interesting. May I ask you probably during the procedure or after procedure, you can see the recording from Holter recording. The ventricular ectropy is about 6 to 10% of the whole recording. According to that, probably is reasonable to do the first of all do the ventricular beat ablation first, because the more ventricular ectropy can induce the ventricular tachyarrhythmia, ventricular tachycardia, or ventricular fibrillation can cause the syncope and so on, as you said. That's my comment.
Mm-hmm.
So we had at least 3 forms of PVC, and we know this is a progressive disease. So what we ablate now, it will not will develop later in a different form, in a different place. And I don't know if Cosmin can show us again one of her PVC. It was an epicardial form, so I don't know if it would be useful to ablate this form, at least 3 forms lead forms, and it is a progressive disease. Actually, stop.
You're right.
Ema,
On the next side, I think it is from the epicardial, because you see the transition in now, Cosmin, please, the previous one.
no, I think this is good one. The ECG in standard ECG was also good. If you look,
okay,
show you the standard ECG. Yeah, that's one.
Also this one, yes, exactly.
Yeah,
Sorry, yes.
look, there is some pseudo delta waves in V1 and V2. One of the beats that might suggest that it's an epicardial origin. But I would ask you something more. Do you think that the right ventricular function or estimation was accurate when your patient has like 8% PVCs? Because on the images that you presented, it looks like there are variable cycle length that image was acquired during cardiac MRI. Could you comment on that?
Yes, my colleague who is performing MRI scan, he's used to do MRI scan also when we have a high burden of PVC, and we give patients some antiarrhythmic drugs before MRI scan. I think the image is not so good because I choose the image and the cycle and everything used in this presentation is not good. But my colleagues, I think, estimated very well his ejection fraction.
And one more thing. I mean, you said there is trabeculation, right ventricular dysfunction,
yes. And
what it's really intriguing is that you have no dilation. So you suggest that it's a advanced disease with dysfunction and trabeculation, and you don't have right ventricular dilation at all. I'm trying. I mean, I'm thinking maybe the dysfunction is a little bit overestimated due to the high burden of PVC, which might happen. It's a discordance in this. I mean, usually when you have dysfunction, you also have dilation.
So we have only the measurements from the parasternal long axis view. I didn't put and I didn't
MRI
do.
is not dilated. That
Sorry,
was
what?
not dilated on MRI.
Yes.
So I think it's kind of discordant.
Okay. Okay,
Well,
so
it's important case, I think, and the lesson is should always look through all the ECGs, not only that we have during arrhythmias, because it's very helpful for differential diagnosis, for identifying baseline disease despite the culprit arrhythmias. But I think it's a very important lesson. Don't jump into conclusion on only one ECG during arrhythmia.
okay. So Dr. Ashihara.
Yes.
Are you okay?
Yeah, I already sent my presentation slide to Dr. Garrett. Yeah, that is right.
Okay, okay.
So
okay.
I have a question. Can I have 10 minutes?
10 minutes? Yeah, okay. 10 minutes. Okay. Please have a presentation. Yeah. Anyway, okay. Please start.
Sorry. Yeah, it's I'm sorry. Very sorry for the technical problem. And it seems that I accepted the presentation without understanding the aim of this session. But I hope you enjoyed my presentation. So this the title of my talk is a practical approach to ECG interpretation, F-wave in patients with non-paroxysmal atrial fibrillation. Next, please. So here you can see the two types of the F-wave. One is the coarse F-wave above, of which amplitude is above 0.1 millivolts, and another is a fine F-wave. The amplitude is below 0.1 millivolts. Next, please. But maybe do you know what is the background mechanism of these F waves? Next, please. So conventionally, it is explained that the structural remodeling, including fibrosis, result in the fine FA. Next, please. Next, please. So indeed, it was experimentally confirmed that, next, please, the FA chronicity caused the irregular and complex wave dynamics. So that, next, please, the cause F wave resulted from the simple wave dynamics, and the fine wave resulted from the complex wave dynamics. Next, please. To confirm this in the clinical situation, we recently developed the clinically available online real-time phase mapping system. This system is based on the intra-atrial bipolarograms recorded by the 24 electrode cassette, and based on this signal, we calculate the calculated by the specific AI and in silico calculation system. Then we get the, next, please, the next, please. Then we get the phase map movies. Here you can see the counterclockwise rotation during the atrial fibrillation. Next, please. And the location of the electrode was navigated by the inside NAVIX system. Then we repeated the mapping in the whole left atrium. Next, please. The accuracy of the external mapping system was confirmed, was validated by the experimental study with the use of the optical mapping study. Next, please. Then we found that there is three types of the wave dynamics. One is the passive activation, prana wave, and the meandering rotor, in the multiple wavelets of the types of the rotors. Next, please. Then we defined these last two as non-passive activations. Next, please. And we found the passive activation and non-passive activations appeared alternatively within the 5-second recordings. And next, please. So this is probably because the rotor meandered inside the left atrium, and there is a high rotor appearance areas. Next, please. So that we calculate the total period time of the non-passive activation. Next, please. And then we mapped in the left atrium, and we try to find, next, please, the higher non-passive areas as an ablation targets. Next, please. So you can see here the higher non-passive areas within the left atrium, and there is a spatial gradient of the non-passive ratios. And then the spatial continuity, there is also the spatial continuities between non-passive areas. So the rotors are controlled by the low power and short duration minimum ablation. Then, next, please. We found the external mapping guided ablation will have an additional benefit comparing with the PVI only. Next, please. So with the use of this system, we try to observe the atrial fibrillation wave dynamics, and we focused on the F wave. So we have the 91 consecutive non-paroxysmal F wave patient, and 56 patients have coarse F wave, with 35 patients have fine F wave, and 10 patients have the severe coarse F wave, of which amplitude is above 0.2 millivolt. Next, please. And this slide shows the baseline characteristics of the non-PAF patients. And here you can see the only non-PAF duration, and the low voltage area significance is significant difference between the coarse F wave group and the fine F wave group. And so the longer non-PAF duration resulted in the fine F wave, and the low voltage area resulted in the fine F wave. Next, please. So it is possible to predict the non-paroxysmal F wave features using only F waves. The answer is no, because there is a large difference between patients to patients. Next, please. So this is one of the atypical patients. So there is a fine F wave, but almost there was no low voltage areas in the left atrial. Please note that the rotors, next please, the rotors within the high voltage areas rotated very slowly. The rotation period is around 200 milliseconds. It's very slow. Next, please. And this is the second atypical cases. Now, there was a coarse F wave, but there was a widespread low voltage areas. So interestingly, the rotors, next please, the rotors within the low voltage areas rotated very slow and rarely accompanied by wave breakups. It is very organized. So in this case, the coarse 5 F wave was observed. Next, please. And this is the third atypical cases. There was a coarse F wave, but non-proximal AFib duration was above 12 years, not the months, 12 years. Interestingly, the most rotors distributed within the high voltage area, not the low voltage area, and rotated very fast. So in this case, the ECG shows the coarse F wave. Next, please. So next, please. Yeah, next, please. So to explain the atypical wave dynamics, we conduct the in silico computer simulation studies, and here you can see the fibroblast, myofibroblast, and atrial myocyte computer model, and we conduct the computer simulation. Then next, please. The left, next please. Left panel is a control case, and the middle is low myofibroblast cases and high density of the fibroblast cases in the right hand. And here you can see in the control case, just rotors spontaneously terminated, but in the middle case, the single rotor meandered, and in the right case, the multiple wavelet types of the rotor was observed. Next, please. So we found that in the simulated ECG, next, please, the low density of the fibroblast cases resulted in the coarse F wave, and the high density of the myofibroblast resulted in the fine F wave. Next, please. So the collagen deposition was not shows the atrial fibrillation because it shows atrial tachycardia based on the anatomical reentry. So this is not AFib. Next, please. So in summary, here you can see the coarse the characteristics of the coarse F wave and the fine F wave. But in this case, in this study, we found, next please, the coarse F wave is again appeared with the more severe structural remodeling. It shows the very organized rotor dynamics. However, rotor behavior greatly varies from patient to patient. Next, please. So in conclusion, next, please. Non-proximal AFib duration and the degree of low voltage area affected the F-wave morphology in ECG. However, it was difficult to predict non-proximal AFib features from F-wave alone, since the rotor behavior greatly varies from patient to patient. Rotor behavior probably depends on the myofibroblast proliferation rather than collagen deposition. Regarding of the F-wave morphology, non-proximal AFib rotors were never stationary, but were evenly distributed and always meandering. So it is my pleasure to, this conclusion is consistent with the experimental atrial fibrillation that for the first time showed the meandering rotor 25 years ago by Dr. Ikeda, who is the chairperson of this session. Thank you for presentation. Thank you for very much for pay attention.
Thank you very much. Very interesting presentations. So, Dr. Ashihara, according to your presentation, types of F-wave That doesn't matter. Using extra mapping, you can eliminate atrial fibrillation by catheter ablation. That's very nice, very interesting. Are there any comments or questions?
Well, I would like to ask Professor Ashihara if he thinks that is rather cycle length of the F waves than the amplitude that may be useful, considering that the amplitude of F waves can be also influenced by the anatomical variation of the thorax of the patients.
Yeah, I checked the many patients, but currently I have no idea because there is no relationship between the F wave cycle length and the rotor reentrant cycle length. Yeah, it's very interesting, but there is not parallel always.
Okay. Other question or comment?
So Professor Ashihara, it's interesting and very great talk actually. Also, the extra mapping system or software is very helpful probably in the clinical practice. May I ask you, how is your strategy for the case? You only target the rotor area, or you target the whole area with the rotor? As I saw from your 3D mapping figure, as you said, probably you ablate the whole area, not the focus. The other question is that why is the result from the rotor ablation is where it's allowed, you know, and also the case not so big. The public paper only some not more than 100 most of the studies. What's your opinion?
So your question is about ablation for the rotors?
Right, your strategy.
Yeah.
Only the rotor only.
Yeah, it's very effective. It's very effective. So the rotor was when we can control all the rotors, observed in the left atrial, then the rotor consistency was very decreased, and in the long-term follow-up, the sinus rhythm was in 80% cases of the patient, the sinus rhythm was maintained.
I think we're young. Dr. Ashihara probably want to say using his specific mapping system, rotor ablation is very, very useful. But the general rotor ablation is not so useful. I don't know.
Okay.
But using his system is probably very useful.
Maybe it's based on the accuracy of the rotor mapping.
Yes, I think so.
From the mechanism side, the rotor can be from the intracardiac to epicardial area. From your extra mapping software, can you identify the mechanism like that?
Yeah, in my mapping system, the rotor inside the myocardium and outside the myocardium, both rotors can be observed. So I think it's very useful to detect the rotor activation, even if the rotor was endocardial side or the epicardial side. It's not matter.
So if the rotor location of a rotor near the line of the ablation line, for instance, the pulmonary isolation line is less than 1 centimeter, would you like to draw the line close the line or not?
Sorry, I cannot follow you. Sorry.
I mean, you have to the PVI.
Yeah, PVI. All
right?
patients are.
And if you find the rotor just 1 centimeter away from the isolation line, would you draw the line from the rotor side to the isolation line?
Yeah, most rotors near the PVI line or the roof line, it's vanished after the PVI. So yeah, one is effectiveness of the ablation, I suppose, That kind of the situation can be also observed with this mapping system. Can I answer your question? Yeah, did I answer your question?
Yeah, full sentence.
Yeah, yes. Okay.
Sorry.
Okay, so thank you very much for all of you. Very nice presentation, and we enjoyed this session very well. I would like to close